So this is our topic today for today's discussion, lumbar spine stenosis, and it's one of the important and health-related issues, especially for the elderly populations. And the therapy or the treatment related to this lumbar spine stenosis, still we have lots of challenges in implementing the treatment to this particular conditions. So we have taken this particular topic for discussion in terms of evidence-based physiotherapy practice. Why this particular topic is taken, evidence-based physiotherapy, even though we have various interventions like electrophysical agents and exercises and or any other special techniques to treat the back pain as well as the especially to the lower back pain and upper back pain, and still there is a lots of debates going on the selection of or appropriate treatment selection for this particular conditions are called lumbar spine stenosis. So we will have a discussion with this particular topic. So always, our as a physical therapists or healthcare professionals, we are providing variety of treatment to the variety of patients in all the fields of the medical field, from pediatric to the geriatric. This lumbar canal stenosis or the lumbar spine stenosis is one of the major health concerns, especially the elderly population above 60 years or above 50 years. So it is our responsibility to implement evidence-based or the effective treatment technique for the those populations or the vulnerable population called elderly populations. So more than knowing, I think everybody or especially in India, we have a lots of knowledge on the various aspect of the health conditions. Still we are not able to produce a effective treatment to this population. So it is very important to understand the concepts of evidence-based physiotherapy or evidence-based medicine. So evidence-based physiotherapy concept, and it is very useful for the physical therapist or the physiotherapist to identify and implement that appropriate treatment for the various at the various stages of the lumbar spine stenosis or any other spinal canal stenosis related to the spine. So, what are the things we are going to discuss here to understand the concepts of evidence-based physiotherapy and interpret the findings from various literature published in the literature in the various databases, and how we can select the evidence-based physiotherapy treatment for lumbar spine stenosis, and finally we are going to discuss about the what is the algorithm uh, for the spinal canal stenosis or spinal stenosis, especially for the lumbar spine treatment. So these are the primary objectives related to our today's discussion. So what is so most of I think most of the students they were attending in the audience, mostly the master students as well as the bachelor students. Okay, so first of all, we should understand what is evidence-based physiotherapy. It's nothing but instead of implementing our known technique to the patients, and instead of that, we will be before implementing the treatment based on our expertise, and we must ensure that whatever the treatment we are producing or providing to the patient or the clients, whether that is very appropriate or very it is going to produce a good clinical outcome on the patient, that we have to ensure. So to in order to make that issue very clear, and this evidence-based physiotherapy concept will be useful for everyone, all of us. So what exactly the World Confederation of Physical Therapy they explain or they define evidence-based physiotherapy? It is a commitment to use the best available evidence to inform decision making about the care of individuals, that involves integrating physiotherapist practitioners and individual professional judgment with evidence gained through the systematic research or systematic approach. So this is a definition given by this British Medical Journal for the evidence-based physiotherapy. It's nothing but what is the available best treatment in the literatures, and we are going to select those interventions and to in order to treat these conditions. Not only for lumbar spine stenosis, and for each and every condition we have evidence-based physiotherapy techniques, and that will be useful for us. So what? So evidence based, the primarily the three areas we should know that. I think in our clinical setup, we all know we are all clinically expertised in our field. For example, in case of neuromusculoskeletal physiotherapy, they are expertise in musculoskeletal neurophysiotherapy. They are expert in their own field. So we know that we are all skillful. Whether that skill is correctly implemented to the correct stage of the disease or the condition, that is only the question mark now. So what are the things, other things are there? So to in order to fill that gap, and we should search in the literatures, what are the, other than our clinical expertise, what are the available treatment in the databases. You search, that is a, what is the best research evidence available for this particular patients. And also we should consider the patient values and the preferences. Okay, so what do you mean by patient values and preferences here? Even though we want to implement correct treatment or appropriate treatment technique to the patients, and the patient should be aware of that, and they should be agree for that particular treatment implementation. So everything has to be considered before implementing the correct treatment to the patient. So so what are the possible evidence we have? We have a different we have a literatures. Various literatures are published in the databases, right? So in all the all the data what we are getting, whatever you are receiving from the different databases, not going to be the same. Some studies will be low in quality, some studies will be high quality. So or the type of study also will varies, the level of evidence or the quality of evidence. It is depending on that we should select the right treatment. Okay, so this is the different studies, their quality, related to the quality. It is given in the pyramid here. When you look at the bottom of this slides, we can see the background informations and expert opinion. These are all the guidelines. These are all, for example, I am expertised in one particular field, and that is my way of implementing the treatment. So that doesn't mean that that can be accepted by everyone. So that has a low level evidence. Then when you go to the individual case studies or case report, whenever publishing it, the case report finding or case report result cannot be generalized to the other population, other in the global, other areas of the global arena. So then we have a case series study, cohort studies, and non-randomized clinical trials and randomized clinical trial. Then critically appraised literature review or evidence-based practice guidelines, systematic review, and finally the meta-analysis. So the meta-analysis is the highest quality or the high quality study. If any interventions it is concluded with it is effective, or it has a high level evidence or low level evidence or moderate evidence based on the meta-analysis, then we can select based on the results from the meta-analysis. For example, the meta-analysis suggests that for example, strengthening exercises is highly. So this is a quality of evidence. Different studies are available in the literatures and the various databases like PubMed, Cochrane, and many more, right? So whenever before implementing any treatment to the patient, even though we are expertised in certain techniques or the certain treatment methods or modalities, we must search the, we should check always for the background support. So in order to confirm that the selected treatment is very effective, we must go and do the background search, and what is the evidence available for particular treatment technique. So this is the different studies are here in the pyramid, and low level evidence for the expert opinion, case studies, and case series and cohort studies, and there will be a high quality evidence for is for meta analysis and
தம்பி இங்க வாங்க.
systematic review. Systematic review is meta analysis. So, as a bachelor degree, bachelor level
அவங்களோட
physiotherapist or master level
நான் மாத்திரம்
physiotherapist, in
வெளியே.
fact, master level physiotherapist, they know about this meta-analysis and systematic review. And for the bachelor students or the bachelor degree physios, they are not very much concerned related to this particular evidence-based treatment. So they can go and search the meta-analysis or systematic review with meta-analysis in order to confirm whether the selected interventions are it is appropriate for the patient or not. Okay, so this is showing that various evidence level for different studies. And what do you mean by quality of evidence here? That is, we must understand that. Okay, so even the Cochrane database, we have different guidelines for checking or criteria for checking the quality of evidence. So they use a grade method, that is grading of recommendations, assessment, development, and evaluation. So based on this grading system, each and every article they will identify the quality of the evidence, quality of the literatures published in the databases in the five different domains. That is, they will check for the risk of bias. Risk of bias means if there is any possible bias or the mistakes in the study or various aspect of the study, where in case of methodological flaws or assessment, that is result analysis bias and many more. So we got that is different the area of vast area of assessment here, risk of bias. So check for the risk of bias, then consistency of finding, whether that particular study findings are is consistent with the previous literatures, that we have to check it. So they will grade the articles based on the risk of bias, consistency of the findings, directness of the comparisons, the comparison whether made with the intervention with placebo group or intervention with the gold standard comparator treatment. Those things they will check it. Then precision of estimates, so what exactly they are analyzing it and what estimate they have got it, and they will consider that also. Then other considerations such as selective reporting. So based on these five domains, and the quality of the article will be quality of evidence will be checked. So based on this five criteria, five domains, and they will be based on the fulfillment of these five, then they will be considering the articles which is available in the databases into high quality, moderate quality, and low quality, and very low quality, like that. So if all the five criteria or five domains are in the positive direction, and that particular studies are considered to be high quality study, and that means that particular study, whatever the methodology they used, okay, that is definitely you can use that information for implementing into the patients. Okay, that the generalizability of the finding is anywhere in the world that can be considered for treatment. So then the next one is moderate. Here is one of the domains. Maybe it's out of five, the only four it is meeting, and other one is not meeting. That means that particular intervention has only the moderate quality, and most of our the treatment available for in physiotherapy for lumbar canal stenosis having the moderate quality, and till now. In the literature, there is no high quality evidence is available for lumbar canal stenosis treatment. Then we have a low quality. The two domains are not met. That means that again there will be some kind of lacunae in the study in terms of methodology or results, and there's a bias, assessment bias or intervention bias might be there. So that means further research very likely to be happen in the future. So low quality studies are three or more domains are not met. So based on this, very simple to understand. There are based on the five domains, they are classifying they are assessing the quality of the evidence, evidence for each article. So based on that, then they are classifying into high quality, moderate, low, and very low quality. So, as a physical therapist or physiotherapist, and what are the steps we must follow to know or to find out the evidence-based treatment or evidence-based physiotherapy techniques? So, always before implementing any treatment to the patient, and at least in a proactive way, and we must work on that background before. For example, you are going to treat the patient. Or you got a one patient, you are not able to provide the evidence-based physiotherapy, and you can do the background search. Okay, just forward the clear answerable clinical, what is the objective, you make your objectives very clear. And then you should, based on the objectives and whether you want to put the immediate effect, you want to look for the short term effect or long term effect, based on that you can go for the vigorous searching and finding of the relevant literatures. Then assess the evidence for its quality and usefulness. And that is, I think, the previous slide I had given this five domains. Based on the five domains, we can check it whether the particular treatment is fall whether high quality or moderate or low quality. Then find the incorporate the patient's values and look for, even though you find it the searched whatever the treatment technique you have selected, whether that particular treatment can be implemented to the patient. Sometimes that patients will not be able to give consent for the particular treatment because of the cultural values or any in socio-economical related, or so in that those values also you must consider before implementing the your treatment. Then integrate the finding in the clinical practice and evaluate the effectiveness always. So you are receiving the patient, you are researching the literatures, you are finding the what is the highest treatment, highest quality treatment. Then that whether the highest quality treatment it can be applied on the particular patients. Then you check the finding, what finding you are getting from the patient for that quality treatment. You must evaluate the effectiveness. Okay, so if the effectiveness is not met, okay, so then you have to rethink about the based on other treatment options. Okay, so most of the time when you apply this evidence-based physiotherapy treatment for any conditions, the effectiveness definitely you will be getting that favorable clinical outcome on the particular patients. That is a prime importance of evidence-based physiotherapy. So still we have lots of barrier for the physiotherapist to apply the evidence-based physiotherapy for in not only for lumbar stenosis, and we have other conditions also. Most of the time, especially in the clinical practice, because of the highest load of the patients for each therapist, because we know that the ratio of patient physiotherapists is very high in case of in the larger population of India. So there is a lack of time and inability to understand the statistics, because even though, that's why I earlier mentioned that all cannot be able to interpret the statistical method, so it is available in the literatures. So we should so that's why in most of the bachelor, even the, I don't know whether in the bachelor when we studied in the in 90s in Tamil Nadu, and we did not had a statistics in the UG program, but only we studied in the master program. So maybe this, I don't know about what statistics are available in the UG program. If it is there, definitely that will be very beneficial for the physiotherapists coming out. Okay, then we have a lack of support from the employer, because all the databases, most of the databases are paid one. So if the databases are and highly they charge, so definitely in individual therapist they will not be able to afford for buying those databases to collect those information. So that is one of the barrier. Lack of resources and lack of internet facility and lack of generalization of the research. So these are the barriers, especially for physiotherapists or those healthcare professionals having low level income. It's very tough, but these are the barriers we must know. So in this aspect, definitely we need to improve our their skills, knowledge and skills, behavior towards this evidence based physiotherapy. Definitely it will be giving very favorable treatment outcome for the patient as well as for the therapist. So, okay, these are the very brief evidence information about the evidence-based physiotherapy. Okay, we must know what is evidence-based, and we are going to check that high-quality treatment methods based on the literatures. Then you are implementing, and also we know still we have some barriers in applying or implementing evidence-based physiotherapy. So now when it comes to the what are the evidence-based physiotherapies available related to the lumbar spine stenosis, we will have a discussion now. Always we must as a physiotherapy student, we are very strong in the anatomy of the our body. So the sound anatomy and physiology is very essential for implementing our treatment methods to the patients. So we must know what are the things are. It's very this is the it's nothing but lumbar canal stenosis or lumbar spine stenosis. We know this. We have the spinal canal. So narrowing of the spinal canal is called as stenosis. We know that. If it is cervical level, it is cervical stenosis, and lumbar level is it is a lumbar stenosis. Both cervical and lumbar, it's a common stenosis can develop. Thoracic level, it is very uncommon. Okay, and based on that. Based on the structural integrity variations, definitely the lumen of the spinal canal may it will reduce. That leads to the compression to the nerve as well as the spinal cord within the spinal canal. That's called. Then it can produce spinal cord symptoms or the nerve root symptoms. Based on that, what type of stenosis is present there. So, when you see the relative anatomical elements to this spinal canal, we can see the posteriorly we have the posterior spinal elements, vertebral elements. Anteriorly, we have vertebral body and the disc. Okay, and we have and also we have in anteriorly we can see that anterior longitudinal ligament. This the one. Then posteriorly we have ligamentum flavum. So. So posterior ligamentum flavum lining the lamina. Laterally, we have vertebral. So these are all very important surrounding area. We must know that. So whether it is prevalent, definitely it is a prevalent when the incidence of the lumbar canal, lumbar spine stenosis is by central. We can have classified into two types: central spinal stenosis and the lateral spinal stenosis. When you look at this, the previous slide, okay, if it is this here, when we can see this image that this particular disc level is going towards the one side, whether the disc is coming directly posteriorly or the thickening of the ligamentum flavum, and if it is there equally, then it can produce central level stenosis. Or if it is only the one side on the lateral aspect of the cord or the nerve roots are compressed, okay, then it can consider to be a lateral stenosis, especially in the lower level of vertebral column and central level stenosis may present most of the conditions, most of the patients. So prevalence is increases with the age related to the 47%. That is a higher one. Okay, relative prevalence and the absolute, this is a 20% almost. So it's a higher rate. So we must have a good clinical reasoning and treatment implication to the patients. Okay, so there are various pathophysiological aspect, etiology related to the lumbar canal stenosis. Most of the time, the degenerative lumbar canal stenosis or lumbar spine stenosis is the very commonest one. Then listhesis and iatrogenic causes, the post-surgical causes, post-traumatic and inflammatory arthritis and disc bulging. These are the common etiology or the reason for developing the stenosis. So, what are the clinical characteristics or clinical presentations in case of lumbar canal stenosis? So, usually the patient complaints of low back pain, numbness, tingling are present in the majority of the patients. And when you look at that here, exacerbated or exaggerated pain by prolonged ambulation, standing, and this will be exaggerating the pain. And with lumbar extension also, it will increase as the pain perception in case of stenosis, relieved by forward flexion and the rest. So when the patient comes to the rest, or when the patient is sitting in the forward flexion, or forward trunk flexion, and it is relieved. That's all the very peculiar characteristics of lumbar spine stenosis. And the very important one, the neurogenic claudication, is the important feature of the lumbar canal stenosis. And the pain and discomfort that radiate to the buttock, thigh, lower leg after walking. It's always after walking, this symptoms will be exaggerated. Uh, and symptoms are typically bilateral. So this is the important point. This is the important point, bilateral. So mostly the symptom will be in case of stenosis bilateral. Then it will be asymmetric, unequal distribution. Okay, even though it is bilateral, is a unequal distribution of the symptom will be there. Numbness, tingling in lumbar spinal stenosis involve usually the entire leg. It is not like only related to the one nerve distribution, not related to the one particular nerve root level. So the dermatomal, all the dermatomal related to the lower limb will be having symptoms, tingling sensation. It's not specific to the single nerve distribution. So walking upstairs easier than the walking downstairs. So this is are all the peculiar characteristics of lumbar canal stenosis. This will be very useful for our diagnosing the patient, whether the patient is having disc related pain, or just non-specific low back pain, or the pain related to the lumbar canal stenosis. So these are the pain characteristics. It's very important for our diagnosis. So most of the patients in lumbar stenosis, neurogenic claudication is the major clinical finding. So based on this neurogenic claudications, and we can able to diagnose whether it is acute, or whether it's the early stage or the late stage. Okay, and that is also will be helpful for determining the what treatment can be implemented to the patient, whether the physiotherapy is indicated or not. So all we should know that what is the characteristics of neurogenic claudication and its severity. So neurogenic claudications occur to the leg symptoms and encompassing the buttock, groin, anterior thigh, as well as the radiation down to the posterior part of the leg. We can see the anterior aspect or the posterior aspect, buttock and groin region. Most of the areas the pains are manifested in this particular cases. That is the initial indication for this particular patient might have the stenosis other than the non-specific low back pain. In addition to the pain, leg symptoms can include fatigue, heaviness, weakness, and or paresthesia. Patients with the lumbar LSS can report nocturnal, that nighttime leg cramps and neurogenic bladder in later stages, and in the severe cases there is a possibility of bladder dysfunctions. Okay, because it is involving with the sacral nerve roots. Symptoms can unilateral, more commonly bilateral, as I mentioned earlier, and yes, maybe it's most I think asymmetrical is not symmetrical. And key features, this again the previous slide we have, lumbar extension increases the pain and flexion will decreases the pain. Symptoms progressively worsen when standing and walking, or relieved by sitting or rest. Relief with sitting in contrast with the non-specific low back pain. It's commonly exacerbated prolonged sitting. In case of non-specific low back pain, it is the symptoms are exaggerated by prolonged sitting. Okay, so long sitting case, that is a difference between the non-specific low back pain with neurogenic claudications related to this. Patients with neurogenic claudication report that lying flat is often associated with less relief. Okay, lying flat is often associated with less relief, and lying on the side permitting lumbar flexion is more comfortable. So if the patient lying on the supine or the flat, whether it is a prone or the supine, that may not give that much relief. That is a less relief will be there when you're comparing the patient lying on the side. When you are lying on the side, automatically the lumbar flexion develop. That flexion will be is useful for useful for identifying whether the particular patient is having lumbar canal stenosis or the non-specific low back pain. So these are the important information related to the characteristics of the neurogenic claudications in case of lumbar stenosis. And the next important one, as a therapist, we must know whether this claudication or the pain symptoms due to the neural involvement or the vascular involvement, because we have vascular claudication because of the peripheral nerve injuries. And I think this slides mostly the differences are given here. Okay, when you see the postural changes, neurogenic claudications will be present, but postural changes, it won't produce any vascular claudication changes in the postural changes, will not going to impact. Okay, then the symptoms, most of the other walking upright, standing, stationary. When you come to the standing stationary, again in case of neurogenic claudication is causes symptoms, but in case of standing stationary, vascular problem will not produce that much issues, that is relieve the symptoms. So these are the primary variations related to the vascular claudications with neurogenic or neurogenic claudications with the vascular level. So we must understand this also. So now we have a different grading for lumbar spine stenosis, and the first one they do it based on the area of the spinal canal, area of the spinal canal, the diameter of the spinal canal, how much it is reduced because of the changes in the anatomical integrity, and based on that they will go for the mild, moderate, and severe. But this, the second one, based on the occurrence of symptoms and their severity, this for the treadmill, using the treadmill test. Okay, this will be very related to our field, the physiotherapy field. This is related to the doctors, the radiologists, they do it. But this will be more applicable towards us, physiotherapists. So when the patients put on the treadmill, they will walk for the 15 minutes. Okay, different level. So after so based on that, they will come to the conclusion that whether the particular patients on the initial stages of the stenosis or the later stages. So in the grade 1 patients who were able to walk the symptom free, even though there is a stenotic features are available. And the second one, patients who were able to complete the test with, that is treadmill test, with some neurological symptom, the patients who were able to walk 5 to 15 minutes. Okay, then the patients who were able to walk less than 5 minutes. So if the patient is having less than 5 minutes, only the patient can able to walk, is not able to continue even after the 5 minutes. That means the patient's having severe lumbar canal stenosis. So based on that also we must it is useful for selecting the treatment, whether physiotherapy can be implemented or not. So now you coming to this is the again classification based on the MRI, and it's also one of the very reliable assessment method for grading the lumbar canal stenosis. And mostly we are not only we are not related to this, only this for radiologist, and this is we must know, just we should know that. Okay, so the severity of the spinal stenosis was associated with the severity of buttock and leg pain and numbness, not with the severity of low back pain. So, in case of lumbar stenosis, the severity of the low back pain, that is a pain in the low back region, will be very less compared to the peripheral pain. That means the peripheral pain will be higher than the low back pain. So we always should to classify that we must you should consider that a buttock and lower limb pain compared to the low back pain for grading it. And when you look at this one, this particular study, clinical classifications of low back pain, the best evidence diagnostic rules. When you check here, spinal canal stenosis, they have this particular authors. They wanted to develop the best evidence for the clinical diagnostic rules for identifying the uh, identifying the specific spinal issues. For here, for the spinal stenosis, and the what are the rules they are given here? Three positive out of five history finding, that is age more than 48 years, and bilateral symptoms, leg pain more than the back pain, pain during walking and standing, pain relief from the sitting, and supplementary physical finding, examination finding, that is improved walking tolerance with the spine inflection or relief by forward bending. So these are the specific notes. So this I'm explaining about this slide, and there are the certain guidelines for diagnosing the important clinical diagnostic rules for lumbar stenosis, and they have age more than 48 years, and bilateral symptom, leg pain more than the back pain, and flexion reduces the pain and extension increases the pain. So these are the diagnostic rules or the clinical diagnostic rules for diagnosing lumbar stenosis. Okay, so this is will be useful for diagnosing it, diagnosing the lumbar canal stenosis. And I'm not going to explain about this other than the physiotherapy in the conservative management, and they have surgical decompression procedures also. For that, they do it laminectomy or hemilaminectomy or the bilateral or unilateral interlaminar penetration and undercutting. These are different minimally invasive procedure or lamina major surgical procedures. They do it. And what exactly we have evidence now for managing the lumbar canal stenosis? This Divan et al. And they have given the some kind of algorithm related to the selection of treatment for lumbar canal stenosis. This is related to the not only for physiotherapy and also for the overall treatment implications selection to the patients with lumbar stenosis. So what algorithm they uses here, and whenever you are they are dividing the four category here, diagnosing the lumbar stenosis. For example, you go for the assessment based on the Zurich claudication questionnaire, and based on the history and physical examination, then you will be finding the red flags. You know that red flags are contraindicated for implementing our physiotherapy treatment. Okay, so if there is, if it is following the criteria or the diagnostic points related to the intermittent neurogenic claudications or the lumbar canal stenosis, then you go for the differential diagnosis. For in case of peripheral vascular diseases, diabetes or peripheral neuropathy, and hip and knee arthritis, lumbar spondylosis, we have to differentiate this condition from these conditions. If the clinical diagnosis of lumbar spinal stenosis, if it is, you look for this one. If it is no, then consider the differential diagnosis and implementing the treatment for those conditions, right? So if these important characteristics of lumbar canal stenosis, if it is identified, then you go for the diagnostic imaging. And we are not, but we will be doing the physical diagnosis. Diagnose imaging, we may not do it. Okay, so based on that diagnostic methods, and there will be a confirmation related to the lumbar canal stenosis. Again, if there is not showing, again you go for the differential diagnosis for other conditions. If it is yes, then and correlate the imaging with the clinical presentation of the symptoms, then go for the medical treatment like anti-inflammatory, non-steroidal anti-inflammatory drugs or rest and other things. And you can educate the patient about the what are the do's and don'ts, and we can refer they will refer the patient for the physical therapy, and along with or without medications based on the patient preferences. So we have a patient education, advise patient about the do's and don'ts, and promote the self management, and reassure the patient. And physical therapy, what are the strengthening the core muscle, stretching, lower limb extremity, lumbar flexion exercises primarily. So if there is no improvement, then we have to think about the other possible treatment other than physical therapy treatment, and it may goes to the surgery level. So if the physical therapy works, okay, so here only we have to select the evidence-based physiotherapy for this particular condition, with the combination of education and the self management, as well as the treatment techniques, which is very effective. If there is improved, then it has to be followed. Follow up has to be done every 6 months. Every 6 months, that physiotherapy treatment has to be checked, and it has to be modified. When he if there's no improvement, then they'll go for the epidural steroid injections, and it's a surgical procedures. So after that, if it is unsuccessful, then they'll go for the surgery. They will do the laminectomy or the minimally invasive surgical procedure. They may do it. If it is successful, and even after the 3 to 4 weeks, then post of steroid injection and physiotherapy, again they will refer the patient to the physiotherapy. Then we'll be able to find it, the what are the best evidence for the post surgical physiotherapy intervention. Then you can apply it, and you follow up 3 to 4 weeks, then like this. And will be, if the symptoms are improved, then continue the treatment. If the developed symptoms, then go for the second epidural steroid injection. Then it's continuous and follow up 4 to 6 weeks. Then if the physiotherapy again fails, then go for the surgical options. So this is the important algorithm used for selecting the appropriate treatment at different stages of the lumbar canal stenosis. So initially, when you look at this algorithm, and importantly, the initially the patients are treated with conservative treatment, and more importance are given to the physiotherapy. Okay, so in terms of flexion exercises or rotational exercises and heat therapy, and we'll think about what are the other possible physiotherapy intervention in the later slides is. So and these slides I will share with Dr. Karthik and Jency, and you can use this algorithm for treatment selection. And what are the non-operative? We are coming under non-operative treatment for lumbar canal stenosis with neurogenic claudication. So this particular study, one of the recent study, they have the primary objective was to identify what is the evidence available for treating the lumbar canal stenosis in terms of non-operative treatment. What they found it here, moderate quality evidence that multimodal approach, which include manual therapy and exercise with or without education, is an effective treatment that Epidural steroids are not effective for the management of lumbar spine stenosis with neurogenic claudications. All other non-operative interventions provided insufficient quality of evidence to make conclusions based on the effectiveness. So I just remember the previous slides when we were talking about the evidence base. What is the quality of evidence? So when you remember that there are five domains, okay, five domains. So based on the five domains, if any one domain, if it is not meeting, that is considered to be moderate quality of evidence. So when you check that this particular study results, this is a systematic review. Okay, so they reviewed the many RCTs, randomized clinical trials or control trials. Then they came to the conclusion that there is a moderate quality evidence for multimodal treatment is primarily related to the physiotherapy, that is manual therapy and exercises, with or without patient education. Okay, this is a effective treatment. That means, so whenever you are going to treat the lumbar canal stenosis patient, you can definitely you can consider the manual therapy and exercises based on the severity, especially in the initial stages of the patient. Definitely you can implement, you can select the manual therapy and exercises. So this is one of the best evidence is available for the effectiveness of manual therapy and exercises for lumbar canal stenosis patients. This is a one study. When you come to the another spinal manipulation and electrical dry needling as an adjunct to conventional physical therapy in patients with lumbar spinal stenosis. This is a multi-central randomized clinical trial. There's a recent study. When you see that is one of the high impact journal, spine journal in 2024, that is recently, it's just in this month it is published. So what result they got it here, at 3 months, this particular treatment group experienced greater reduction in overall low back, buttock and leg pain. Okay, the NPRS, these are the ANOVA statistics, and just leave that. And the related disability, there is a pain reduction, related disability outcome compared to the conventional physiotherapy group. Okay, when you are implementing or when you are adding spinal manipulations and electrical dry needling and in along with conventional physical therapy, and it is giving more beneficial effect to the patient on the in terms of back buttock pain, low back pain and leg pain aspect, and also the disability. So what the effect? The effect sizes is very small at 2 to 6 weeks. That means in the short term they have a smaller effect size. That means it is produce a less improvement. That is less is produce a changes in the clinical outcomes a little less. When it goes to the medium, the 3 months medium effect size they are getting it, and at 3 months. Uh, it's a we can see that at 3 months for the NPRs there's a pain medium for medium effect size at the 3 months for the NPRs disability, and this all other outcomes. So that indicates that when you are adding the spinal manipulation and electrical dry needling along with the conventional physical therapy, that is exercises, okay, and definitely it will be useful for the patient. So what they have concluded here, patients with lumbar spinal stenosis who received electrical dry needling and spinal manipulation in addition to the impaired based exercise manual therapy and electrothermal modalities experience greater improvement in low back, buttock and leg pain. So this also one of the recent evidence. It gives us some kind of input to us for implementing the treatment to the lumbar spine stenosis cases. Then we can see the another guidelines. This is the conservative treatment and percutaneous pain relief techniques in patients with the lumbar canal stenosis. So based on this study, this also the recent study. I think I have taken the recent last 5 years. What are the studies are available? I have taken for this today's discussion. So there's all our recent studies. So what this particular studies they are suggesting for especially for physiotherapy modality. So what are the physiotherapy modalities are having moderate evidence, Okay, that's low to moderate evidence, not high evidence. Low to moderate evidence. Exercises, that means flexion exercises and treadmill training and cycling, it has the good effect. Manual therapy, as we have discussed, mobilization and manipulation and traction also, it has that. In fact, the traction has a low level evidence, but it is useful for certain patients. Then instrument physical therapies using ultrasound and TENS and heat pack also useful for reducing the clinical signs and symptoms of LSS. Other modalities like acupuncture, aquatic therapy, there's a hydrotherapy, psychosocial intervention, and TENS, that is transcutaneous tibial nerve stimulation. These are all having some kind of low to moderate evidence according to their recommendations. So these recommendations provide what is the best treatment available for patients with lumbar canal stenosis. And when you look at the different studies, and primarily the flexion, the treatment focusing on the trunk flexion, we have the trunk flexion, we have the lumbar flexion, okay, and also we have the traction here, manual therapy, manual methods. So most of the interventions, whenever you are implementing to the patient, make sure that and your treatments are focusing on the flexion, not related to the extension. So that particular concept or the that particular point, always you should remember that. Otherwise that particular stenosis can produce more mechanical pressure, then it can the symptom can reoccur. So these exercises should be flexion based, not in the extension based. So definitely the mulligan will not be McKenzie will not be very effective. Definitely we must avoid in this case. So this another study, we can see this 2008 again, the Spine Journal. Okay, what they have done the study, patients can experience with non-surgical treatment for lumbar spine stenosis. This qualitative study, they wanted to know that what about the patient's opinion on the various treatment given for the non-surgical treatment given for them. So what is their opinion about that? So what the result found it, uh, the patient prefer individualized treatment that is tailored to their specific impairment functional limitation. What is, see that the patients are giving very clear input to us, so that we can change our treatment techniques from patient to patient. So these are all patients' comments, not the therapist comment, the patient's comment. They prefer individualized treatment that is tailored to their specific impairment and functional limitations. And also they want to learn self-management strategies, because most of the every time the patients cannot able to reach the healthcare centers because lots of difficulties are the transportation and financial many more. So they wanted to learn self-management strategies. So in this related, and this patient education will works very effectively in these cases. And when you see that exercise improve their pain level and physical education, see the patient's perception on non-surgical treatment. Exercise, they are specifically, they note that, they give the input that exercises improving their improving their symptoms. So when you see the another comments from them, effects are temporary, so commitment to exercising long term is important. So they know that. So when you do the when you do the exercises regularly, and the effect will be long lasting. And if it is irregular exercises, if the patients are having irregular habit of doing exercises, and there the effect is going to be temporary. So they also know that the exercises has to be continued for a long time, right? So these are the primary comments they got it from the patients based on this particular study. So these points will be very useful for implementing our exercises to the patients. Then we can see there's another study, again 2021 study, Chiefs of Physical Medicine and Rehabilitation, and the effectiveness of conservative non-pharmacological therapies for pain, disability, physical act capacity. and physical activity behavior in patients with degenerative lumbar spinal stenosis. This is one of the high quality studies, systematic review with meta-analysis. So definitely we can rely on this finding from this particular study, since it is a high quality study. So what exactly in the study they have selected 19 trial, which included 1432 patients. Okay, so among the 19 trials, 19 studies, so what the result they got it: directed exercises manual therapy was superior to self-directed exercise or exercise group exercise for improving short-term walking capacity. Okay, so low back pain, leg pain, and moderate quality for the symptom severity. So when you see that the points in the first point, and the exercise directing to the particular issues with the patient, that is impairment based treatment, definitely that is considered to be a superior to other interventions. Okay, so exercise and manual therapy was superior to self directed exercise program, right, for reducing pain or walking capacity and physical activity. So it has a moderate quality evidence, they also suggest. Then there is a very low quality evidence that rehabilitation is no better than surgery at improving intermediate or long term disability. So, there is a one single trial in this study provided conflicting evidence of effectiveness for the variety of therapies. So sorry, so what is important here from the study, since it is a high quality study meta-analysis, they are providing this exercises and manual therapies were superior. So definitely without any hesitations, and we can implement. Then this is another additional one. Just I wanted to know how they are breaking the addition in case of ligamentum flavum additions. They wanted to do the percutaneous additional lysis. That's breakdown the additions, and they also done some kind of this particular treatment for chronic central lumbar canal stenosis or spinal stenosis. They that what they overall they identified, the present analysis show that level 2, that is moderate evidence for percutaneous reversal. It is not, we can see this also having moderate evidence. Our exercises manual therapy also has a, moderate evidence. So till now, based on my search, there is no high quality study, for any treatment related to the non-pharmacological treatment or the conservative treatment, including physiotherapy. So physiotherapy has a which evidence, moderate evidence for managing the signs and symptoms of lumbar canal stenosis. And before implementing any disease, any treatment to the patient, make sure that if there is no red flags are identified. If there's red flags are there, and you are not supposed to give exercises or any kind of minimally invasive treatment techniques such as electrical needling or dry needling related also. So, so as far as our today's discussion, I think you might got some information about what is evidence-based physiotherapy, right? What are the different articles or the studies, their level of evidence? What are the 5 domains related to related to checking the quality of the evidence, and what are the literatures, recent literatures available to identify the type of treatment or physiotherapy treatment, um, and its effectiveness on lumbar canal stenosis. So this information may give the some kind of initial input to you, and based on this input, and you can go and search the literatures again, and you can implement the interventions to the patients, those who are coming to you with the lumbar spinal stenosis. I think in future we will think about any other possible recent advances, and we can have a discussion if time permit in future. So always it's very important to understand the concepts, implement, interpret the findings, and select the appropriate treatment. Then check for the improvement, analyze the improvement, and then you change the treatment protocol based on the improvement. If the improvements are achieved, and you no need to continue the same. If the improvements are not reaching your expected objective, then you need to look for the modification in the treatment protocol for any patients, not only for this. Okay, thank you so much.